Well, good afternoon, ladies and gentlemen. We're smaller in number this afternoon, but that doesn't mean anything. Probably means it's more intelligent, perhaps, the audience. Thank you. Anyway, it's lovely that you're here, and it gives me a great deal of pleasure now to introduce the local multiple sclerosis field officer, Joe Smith, in the second of our seminars today. And Joe is going to outline the issues and the facts of living with multiple sclerosis. And I understand you're going to get some help from some other people towards the end of your talk. So thank you, Joe.
Well, thank you. When I put together this presentation, I sort of covering a lot of what actually MS, what multiple sclerosis is. That's kind of my part, and then I wanted to hand over to two of our society members that are actually the experts. They're the ones that actually live with MS that will be able to possibly answer your questions. So, Okay, so the Otago Multiple Sclerosis Society, or MS Otago, is one of 18 regional societies. We're actually based in Baker Street in Caversham. We're a not-for-profit organisation, and we're devoted to supporting people with MS and other neurological disorders. Some of the ways that we support our members is with support groups, advocacy, providing them with up-to-date information, etc. So what is multiple sclerosis? Does many people know what it is? Anybody? I see sort of a few hands. So you two know, well, I hope you do. So I tailored this around people that actually don't know much or anything about multiple sclerosis. So multiple sclerosis is one of the most common diseases of the immune system. It is a variable condition that has no predictable set pattern. Symptoms can vary from person to person, and as I've heard, 100 different people have 100 different symptoms. In my time working with MS Otago, I don't think I've met one person or two people that share the same symptoms at the same time. So it really is that 100 different people, different symptoms. It is a variable lifelong condition affecting multiple sites of the central nervous system, leading to lesions and scars, which is the sclerosis, within the brain or the spinal cord. MS is neither contagious, and nor does it necessarily mean that someone's going to end up in a wheelchair or become wheelchair bound. Okay, so here we have the central nervous system, which is the brain and the spinal cord, and I'm particularly going to talk about the peripheral nerves. So what I found is a really good example is when you go to pick up a hot cup, the peripheral nerves sense the heat and tell the central nervous system to actually leave the cup and put it down to let it cool down. Then the peripheral nerves tell the muscles in the arm to put the cup back down. So the peripheral nerves are like the tentacles in the nervous system. Then we talk about the importance and the loss of myelin. If you can think of an electrical wire, this is the best way it was described to me, and the outer layer of the electrical wire, the sort of the rubber, the plastic, is actually the myelin. So our nerves are wrapped in a protective sheath called myelin, and in multiple sclerosis, the myelin sheaths are injured by an inflammatory process. And inflammatory reactions can be spotted in MRI pictures of the brain. And the symptoms depend on the location of the demyelination in the brain and the spinal cord. And MS, for some unknown reason, perceives the myelin around the sheaths to be foreign, leading to a site of inflammation along the nerve pathway. And the myelin is eaten by the macrophages, which is also known as the cleaning crew of the immune system. The axons are left naked and cannot conduct electrical impulses effectively. So when you're thinking of that electrical cord, if it gets damaged, it's not going to transmit as well as it would if it wasn't damaged. So here we have the nerves. So injury to the nerve fibres leads to impaired transmission and loss of function. this leading to a relapse is when symptoms disappear or decrease. So the top, you can see the nerves there. The top picture is what they would say will be an average nerve cell, and you can see there's no sort of deterioration there. The one down from there shows actually it's the scarred myelin and the damaged nerve. I've also got a picture here of a brain scan of someone that has multiple sclerosis, and you can see the lesions that are actually on the brain. So when the inflammation subsides, repair mechanisms are set into motion. This is called remyelination. Remyelinating nerves cells tend to have thinner layers of myelin and shorter nodes. So in that picture, the top one is a normal or average axon. The one down is the one that's been demyelinated. And then when it remyelinates, or when it actually repairs itself, it can be a lot thinner and a lot shorter, and it tends to be, the myelin sheath tends to be a lot thinner than it would on a normal axon. The cycle of injury and repair occurs over and over again, but multiple scars, which is multiple sclerosis, are left behind. So many symptoms, and some of the symptoms of multiple sclerosis is fatigue, cognitive impairment, depression, visual problems, speech, throat, musculoskeletal, weakness and spasms, sensation, bowel incontinence, etc., and urinary incontinence frequency or retention. And how is it diagnosed? So many neurologists use a combination of tools to diagnose MS. Patient symptoms and experiences, magnetic resonance imaging, which is MRI scan, that reveals patches on the brain or the spinal cord. Spinal fluid examinations, like lumbar punctures, can determine and can show certain proteins that show the evidence of the myelin damage. And also electrical studies of the brain may indicate disruptions to the nervous system. And so who's most susceptible to developing MS? Very, very much a Caucasian, European descent, as you can see in the pie chart here, the grey area being that. Then we've got the blue, which is other origins, which could be Fijian, Maori, Indian, etc. And obviously the African origin there as well. So it is very much a white person's disease. So MS is most common amongst young adults between the ages of 20 and 40. And that actually really surprised me when I came across that, because it is very much a young person's disease. It affects people in more cooler climates, so Dunedin's not good. Furthest from the equator, with a percentage of the population being much higher in Invercargill than in Auckland. I'm not sure of the actual figures there, but it's quite significant. And also women, at the moment it's approximately every 4 women is 1 man. And again, it says the Anglo-Saxon European descent. And the different types of MS. There's relapsing remitting, so 80% of people that get diagnosed usually get diagnosed with relapsing remitting. 40% of people with relapsing remitting go on to develop secondary progressive. 10% go on to develop primary progressive. And obviously benign is when someone has had little or one initial attack with full recovery, and it may be 20 years before they have another relapse or attack. And so the big question, what causes MS? Well, nobody actually knows. It's very unknown as to what is the cause, but it's suggested that it's viruses may be responsible for MS. I recently heard someone say about glandular fever, but there's actually no reliable scientific proof so far that any specific virus causes this particular condition. And as I've got there, it could be the climate, living in the wrong climate, the race, your age, viruses, and genetic dispositions. And so the treatments. So multiple sclerosis cannot be cured, but the symptoms can be managed. 3 treatments are available in New Zealand at the moment, targeting the nervous system. They're known as betafuron, Avonex, and Copaxone. Best results occur when treatment is used early on in the condition and has met a narrow criteria for funding. So we at the Otago Multiple Sclerosis Society aim to empower people with disabilities and their families by providing them with information and skills to enable them to participate actively in the community in ways that are meaningful for them. So I'd like to introduce Mel Hogue and Trina Lyon and Bruno, and these are the people that are the real experts and that are actually living a fulfilling life with multiple sclerosis. So, Mel, would you like to come up first?
So this is the point where we would invite some questions, and got lots of experience here to answer them. So do we have anyone like to kick off with a question? You'll never get a better opportunity. Yes, ma'am.
Is it hereditary?
Is it hereditary is the answer. Was the question, rather?
No. There is some evidence, but it's not enough to be proven, so not really, no.
I think that's very typical of most neurological conditions. There is a small percentage of hereditary connection, but nothing to lie awake nights worrying about. No.
However, they do say if you've got some twins and one has multiple sclerosis, then the second one has a 25% more chance of developing MS.
Oh, there we are. Statistics are never wrong.
No, statistics are never
Sir.
wrong.
Do we know why colder climates give more reason to it?
Do we know why cold climates?
They think it's something to do with vitamin D. The further you are from the equator, the less vitamin D you get. So
would having vitamin D supplements sort of...
we do.
Yeah.
We do. We all do.
The latest Neurological Foundation newsletter out there has some research on that. So that's, yeah.
And I think there's more research going on at the moment, isn't there, through MS New Zealand with vitamin D and stuff.
But in saying that, it doesn't cure everything. I grew up in a sunny climate. I spent my summers outside in the sun, and here I am, so...
Okay. There was a gentleman up here somewhere. No? Behind. Oh, here we are, over in the... Yes, ma'am. Here we are.
What are some of the key challenges that you face living with MS, especially some of the things that might be unexpected?
Cutting toenails. Getting up every day. Housework.
Fatigue.
Just being able to function normally.
And it's an invisible illness. It doesn't look like there's anything wrong with me, and people look at me and go, why aren't you working full time? You know, why are you on the invalid's benefit? And because you look like there's nothing wrong with you.
Staggering down the road at 8 o'clock in the morning looking like you're a total drunk, you know, falling over for absolutely no reason. And as Mel says, we look perfectly normal, but we're not. And once again, I can't work full time. He's just trying to tell you how it affects him. But yeah, so just everyday little bits and pieces. I can't cut my toenails because I can't control my leg, and I tend to stab myself, which is extremely painful. Just walking along the street for no reason and collapsing, you know. It's just, and every single day, and the fatigue, particularly at the moment with the heat, is really, really bad.
I actually got told when I was living in Hamilton that with someone with MS, the heat affects the nerve endings 10 times what it does the average person, which is why in hotter climates we tend to just crash.
And sometimes, you know, I remember visiting a lady who said she'll get up in the night to go to the toilet and she'll come back and her legs lock. And she's standing there going, I want to get back into bed. And you know, I know that I don't sort of think about those things, but that must be really challenging.
It can be. Sometimes the amount of times you're up during the night.
Yeah.
No, I've got it. Do you know if any dietary changes help with MS at all?
Some people it does. When I was in Hamilton, they were really pushing, the MS Society up there was really pushing the Jelinek diet, which is vegan. And I know some people felt a lot better on it than me, no difference. But some people say certain diets can work.
MS Otago, we did get the nutritionists in last year and they were doing a survey through the university. I don't know if we've had any results, but they actually got us to fill out a whole lot of forms to see how we ate and what affected us. And I guess that's up to you guys to see how the university is actually going with that, because there was exactly that going on, seeing if there was dietary things that were going to help us.
I think that's really interesting, and I will follow that up actually. But also when people talk to us about, you know, should I be eating something different or not eating something, we very much talk about that well-being and having a healthy, balanced diet, which is true for everybody.
Yes, ma'am.
I was just wondering, what were the messages you received from your body that led you to go and get, I guess, tested or diagnosed with MS?
With me, they thought I'd had a stroke. I'd had a couple of episodes of optic neuritis, disturbance in my eye, and the last one they thought I'd had a stroke. So they did an MRI, and that's where they found the lesions. And they came back to me and said, "You didn't have a stroke, you've got MS."
Oh, right.
And to this day, apart from the fatigue, my worst problems are my eye problems.
And mine is my leg just started wearing very quickly. I've always been a very physical, busy, full-time working, you know, running 40 acres and stuff. And my leg gets very tired, and I actually started to lose between there and there. I just can't feel it. And I had an MRI within 10 days of going to neurology and was told I had MS. Unfortunately, I'm progressing, so.
So is that what you would call an attack? Like when your leg freezes up or when your eye...
For me it was. I've had 3 or 4 episodes now.
Okay.
And they've all been in my eyes.
Whereas mine now is progressing. My leg is tired all the time, fatigue, so I've actually got what's known as secondary progressive. I missed somewhere along the way. I've had it, but I didn't know I had it way back, because I'm actually only been diagnosed 2 years, which is, I'm old to be diagnosed, if you like, because I'm 45, and that's old to be getting diagnosed with MS.
Whereas I was 29, I think. It was 07. And initially they wouldn't diagnose mine officially because I didn't tick enough boxes, but they ruled everything else out. So it was only in 2010 that I was officially diagnosed.
So how long did that take for them to diagnose you?
3 years.
Oh, wow.
And it was, whether or not it says anything about Otago, I don't know, but it was when I moved up to Hamilton and I went for a checkup and the guy said, "I think you've definitely got it." He did a series of lumbar punctures because they couldn't get in, and they did another MRI. And it was the MRI that showed the changes that really confirmed it.
Right. Thank you.
That's also one of the problems too, it mimics so many different diseases.
Yep.
It mimics so many different diseases. They've got to, get rid of all the other possibilities.
Yeah. Well, I mean, my mum for years was asking if I had lupus, and it was that final diagnosis that stopped her asking.
Yeah. And, like my symptoms were pins and needles in my hands. I thought it was just a compressed nerve or something. And, I've still got pins and needles 15 years later or whatever, so.
Well, I know
it could be anything.
with me, the registrar over at the hospital just thought I had muscle weakness. He just thought I'd lost some muscle, had the MRI, and he said before he even looked at the other stuff, he said, "You've got it. You've got lesions in your brain and your spine." He said it's MS, but we have to do the others to rule out the rest. But yes, it took 10 days really for me.
Whereas mine was more like 4 years.
So can I ask you ladies a question? Okay, sorry, after you.
What's the medication that's available? What does the medication do, and what's the criteria that you have to...
Do you know the criteria, Joe?
I do know the criteria.
I'm not on any medication with secondary progressive. There is a drug, but I can't afford $800 a month to pay for it. If I was in Australia or anywhere else, it would be free.
So is it government funded and you have to be pretty bad to
You have to
get
jump
that?
through hoops. to get it.
Okay.
And vitamin D is the only other thing I take.
The medication that I mentioned, the betaferon, Copaxone
And the
and Avonex, are the ones that are funded at the moment, but there is quite a strict criteria. Someone presents, have had all the tests done, they've had an attack or relapse, and it's their first one. Before they can get on any kind of medication, they have to have another one within a 12-month period. But then research has shown that the earliest they can get on medication, the outlook is so much better. So when I recently visited the neurological department at the hospital, they're really looking at getting that changed. And I do believe in Australia you can go straight on with just one, with your first attack.
One of my friends who is in the gym, one of our groups, her doctor told her to go back to Aussie because she'd get much better treatment over there. And I know I'm on a Facebook page with a lot of people in America, and some of the stuff they're talking about I've never even heard of.
Yeah. It seems like a catch-22, isn't it? Because you need to get on it quickly and then...
Yeah, I got on it quickly, I don't know how, but I've been relapsed for 3 years this month, and I've been on medication for 18 months.
And are there any side effects that you've noticed with the medication that you're on?
Yeah, I'm on Avonex, which is a betaferon. It's... I don't know that much about it, just because I hate it. I hate needles. It's injecting once a week into my thighs, and because I've got such a big fear of needles, my mother does it for me. And I've noticed my hair has dried out. I'm no longer allowed to dye it. That's been the biggest one for me. Some of the side effects, like you get flu-like symptoms the night of it, and actually compared to some of the people I've seen on it, I get them pretty mildly. And for me, the biggest one is insomnia. On it, I wasn't sleeping the night I took it. But some of the ladies I know on Avonex, they can be sick for 2 or 3 days.
So how often do you take it?
Once a week.
Oh, okay.
The Copaxone and the betaferon, one of them's daily and one of them's every second day, but they're like the diabetic injections. So they're very... But even then, they can lose pockets of skin where they do the injections, because I know I'm getting scar tissue in my thighs, so it's getting more painful.
So do you alternate where you would inject?
Yeah, it's one leg each week. Yep. I've got it written up on the calendar which leg it is, because I don't remember. And I find icing, it doesn't help physically, but it helps mentally. Because some of the injections, if you hit scar tissue or a nerve, can be really painful. And hitting a nerve is always fun because it bleeds like nothing else. It's quite entertaining, actually. Sorry, not a nerve, a vein.
Okay, how we going? Any more questions anywhere? Okay. Thank you so much, everybody, for those questions, and thank you, ladies, for fronting up like that and talking so openly and freely about your condition. We really appreciate that. Thank you so much.
Thank you.
A special thank you to Joe from the Multiple Sclerosis Society. I think all of you are going to be around for the rest of the afternoon, aren't you? So if you are available for talking to people, that would be lovely. And thank you so much again. Really appreciate it.